let's talk a little bit about the procedure itself. I take a very typical approach to this, and I'll show you some pictures that were graciously provided by one of my clinical partners, Dr. Joseph Park, who is a faculty member at Western University. So obviously the first thing you're going to do, of course, is to make an incision. And a pretty typical incision, just in some instances a lot like a typical bunion approach, is a dorsal medial incision, just medial to the extensor hallucis longus. The incision typically starts just proximal to the proximal interphalangeal joint and extends a little bit past the metatarsal head so that we can have adequate exposure for a plate and screws if that's the sort of method of fixation that you want. The next, of course, is the dissection, and I usually only remove enough tissue off of the metatarsal to allow the plate to sit and for us to be able to debride the joint. You'll notice that in this picture, the Montgomery elevator is used to release the sesamoids, which is oftentimes necessary in order to get complete correction and adequate positioning of the hallux. I typically, like many, will leave the adductor hallucis attached to the proximal phalanx because it's not necessary to remove this, and it will actually act as a stabilizer on the lateral side. Next, of course, comes the joint prep. I tend to avoid a planal resection method. It's much more difficult to get the hallux exactly where you want it, and it has a lot less variation, or the ability to vary the position of the hallux. So you'll see this is using a cup and cone reamer system. This is the cup in this case, and I'm going to show you this video of the Dr. Park doing the fusion procedure, and you'll notice that they're not just pushing hard on it. You start the reamer and you run the drill, run the reamer, and you gently remove the tissue. It's very easy, especially if there are cysts inside the head, for that reamer to crush the head, and then you lose all of that joint material. Okay, so the next, of course, once you prep the head, is prepping the proximal phalangeal base, and you can use the cup reamer. I have used that as well. I have since changed my own personal method to using a burr. I just use that to round it. I have found that the cone reamer is actually not sharp enough in most of the systems, and so it's very easy to then, as you're going, it's taking a while, and then you push and you crush it and you collapse the proximal phalangeal base. I find it a lot easier to control the shape of my proximal phalangeal base, and also I could do a little bit less dissection. I don't have to pull the hallux down quite so much. If you do use the cone reamer, you have to make sure that you plantar flex the digit enough that you don't hit the metatarsal head with the reamer. If you do, you're likely to damage the head of the metatarsal. Next comes drilling, and just like what we talked about with the article about the joint prep, you want to violate that subchondral plate. You want to violate that zone of calcified cartilage and really drill that head well. I tend to flush before I do this step, and then after drilling, I leave the material in the joint space. You get all that bone to sort of fill up those spaces. Then comes your position and fixation. I tend to fix my hallux with the nail facing up. With the hallux in a rectus position, I tend not to transversely make the digit parallel to the second, especially in patients who have hallux valgus. So hallux valgus patients, I will actually try to make that digit as rectus as I can in line with the metatarsal so that I can close the intermetatarsal angle. If I leave it abducted, then you're going to have a failure. You'll have less likely ability to close that IM angle well, because it's the retrograde force of the hallux on the metatarsal that's really going to correct that IM angle. And then I tend to use, for me, I tend to use a screw and plate method, with my screw going from the proximal phalanx to the metatarsal head. Occasionally I'll go the other direction, but it's technically a little easier to do it that way as opposed to the head into the phalanx.